All right. Wow, thank you so much. That was great. The way the sessions are organized is that we'll hear 3 presentations and then we'll have time for Q&A. We'll bring all the speakers back up for Q&A. So next, we're going to turn our attention to work that we are doing in the area of caring, palliative care for people with neurologic illness, which has really become sort of a focus, a specialty, I would say, for us here at UCSF. And I'm delighted to bring up Kwame, Adjepong, and Bridget Sumser, and Natalie Young, who are leading this work.
Hey everybody, thanks for being here. My name is Kwame. I'm a neurologist and a palliative care doctor.
Bridget Sumser, social worker and health educator, and we're just going to do a real dance here around this microphone.
I'm Natalie Young. I'm a geriatrics and palliative care doc.
And so our hope today is to provide a little bit of a background about the work that's been done so far and starting to think ahead about some of the projects and ideas that we hope to be able to implement here at UCSF over the next 25 years. I wanted to start with a patient encounter and just hear a little bit about the impact that palliative care has had in one particular disease, and we'll be talking about additional diseases thereafter. Let's see.
I don't know if it's the video, because that was plain audio.
Okay. I guess it won't be a video. Okay. Fortunately, there will not be a video. I'll mention this patient has been navigating ALS and has been spending a lot of time in our outpatient palliative care service and was simply asked about what the impact of palliative care was on their experience overall. And they first start by launching into how they've never actually met with a chaplain in their life before and finding all of the support and being able to work with Sarah, our provider in the outpatient palliative care service. They go on to explain the benefit that they've received in working with social work and to have this team that's able to think about the entirety of the experience, both for the patient navigating the illness, but for their care partner as well. And I want to talk a little bit about some of the experiences that we've seen as we've been working with providers, patients, families, trainees at UCSF as we've been navigating neurology and palliative care.
So one of the things that's so motivating and also incredibly humbling about this space is the amount of distress that we see in providers. And part of the distress that we see in providers mimics the sort of exquisite distress that we see in caregivers in this space. And it's around, what do we do? And how do we do it? And how do we manage this potentially for a really long time, when the course of what's happening in someone's body and therefore in their family, in their home, with their work is rather unpredictable. And so much of the foundation of what we've been bringing to this work is how do we understand the pain points of everyone involved, patients, families, community members, providers across specialties and professions and disciplines, and really grounding our interventions and the work we're trying to move forward from this place of we all need each other significantly in this work, and there is much sort of care and healing to be provided for everyone.
And so this idea of being able to provide education and exposure to trainees that are navigating all of this and in the future caring for patients with neurological illnesses has been studied a lot in the US. And there's been found to be a lot of variability in both the skills that trainees feel that they have and in how it's delivered to them. Program directors, trainees, identifying that serious illness communication is a real challenge for them. And yet the dedicated curriculum for it, again, is quite variable from institution to institution. And so follow-up studies looked at potential barriers and the reason why that it seems to exist. And people identify that there's a lack of expertise kind of in this blend between the two fields and being able to provide the specific education that's pertinent for the patients that are experiencing neurologic illnesses. We'll be touching on this in a little bit. We conducted a survey here, taking a look at how some residents in the neurology residency identify the skills that they have in a few of these different domains that we all know so well in palliative care. And the ideas vary. People talk about their experiences with serious illness communication in terms of goals of care conversations in the hospital, thinking about how things proceed and thinking about advanced care planning simply as a code status conversation or a pulsed form and not going into the additional detail and the nuances that we've all come to know so well. And so one interesting finding was about the senior residents who've been through most of the training of reflecting on the positive exposures they've had so far and the heterogeneity there, where if they just so happen to have a provider that's able to provide this particular detail, provide that feedback, they really learn a lot. And the junior residents sharing that there's an expectation that they would be able to learn these skills over time because it's such a core need in the neurology training.
Thankfully, there's increasing recognition on the importance of palliative care in neurology and advocacy for these collaborations. And yet there's still significant challenge and barriers to being able to access this care. Again, as Bridget alluded to, so much that we see in neuropalliative care is this challenge and burden on caregivers and how do we best care and support these individuals and families. And a lot of that has to do with healthcare policies that create these barriers, siloing of providers and where are these patients cared for, who is primarily responsible, how do we integrate and coordinate our services. And again, as Kwame alluded to, gaps in palliative care education for neurologists, neurology residents, as well as neurology education for palliative care providers who are predominantly internal medicine trained and don't necessarily have the same exposure to caring for neurologic disease. And finally, there is still significant stigma in palliative care, as has been discussed already. One of the things that we have experienced is the unique kind of needs of this population. It is different from traditional palliative care as we think about it in terms of symptom management with pain control or shortness of breath. The symptomatology is very different for this patient population and I think requires, again, additional training, resources, experience, and again, speaks to the significant distress that we often see for providers, or for patients, providers, and family members.
When we think about psychosocial and spiritual care, we're really talking about community-based issues because we're talking about systems of social care, like Irene was talking about this morning. And so efforts to do neuropalliative care better have to expand outside of the healthcare system and include community-based organizations and groups, folks in the community really connected to people's everyday lives. I think one of the most humbling things for me in this space is sitting with caregivers and just feeling so viscerally what it is that they're holding. The intensity of daily management over weeks to years to a decade, with this underlying grief that is there and palpable and often feels immovable, right? So many meetings providing behavioral strategies. How do you manage an otherwise healthy body with a mind that's not working? Caregivers in tears, just furiously writing notes around how can their world be manageable, right? So how do we do this dance between the intensely practical and logistical with the deeply sort of existential and emotional?
to this idea of traditional approaches in palliative care, advanced care planning often runs core to the conversations that we have. And with neurology patients, like was mentioned before, things are a bit different. Very early involvement of decision makers. You can think about it with someone on the outpatient side who starts to develop some of these cognitive symptoms. You can think about it in the hospital when someone comes in with a severe acute brain injury, and from the beginning, the conversations are with the friends or family around to help try to decide about the care that they may want to receive because they're unable to do so on their own. And so now this has been reflected in the American Academy of Neurology, the ACGME training institutions talking about the responsibility of providers to be able to provide some of these skills to patients experiencing these illnesses. And it's a responsibility for all of us to be able to share this skill set as much as we can with all the different providers that will interact with these patients and families. As was mentioned before, with the idea of fluctuating needs over time, a study looking at neuropalliative care needs in this population looked at the fluctuation in palliative care needs over time. Unlike other illnesses where maybe some needs can be anticipated and progress over time, there can be really variable amounts of palliative care needs and distress that comes up in these multiple domains that all of us spend time thinking about. And so being able to identify those things at the time of diagnosis and over the course of the illness itself is a really important piece that we hope to be able to share with trainees and providers that are thinking about how to provide and when to provide palliative care for this population.
So our vision for neuropalliative care at UCSF is to really try and have an interdisciplinary approach to addressing all of these different domains, kind of coordinating clinical care, education, research, community partnerships. And our vision is really for all people experiencing serious neurologic illness to have equitable access to high quality palliative care. And as part of that, our mission is to build an interprofessional team focused on the delivery, education, dissemination of palliative care for people experiencing serious neurologic illness. Some of what we're doing in our current clinical care and collaborations, Cara Bischoff is really leading the charge of integrating with the ALS group here at UCSF. We have been working with the Memory and Aging Center to develop a collaboration for specialty palliative care for patients with dementia with the Memory and Aging Center. As part of that, we've developed an innovative group medical visit for patients living with dementia and their care partners to address early palliative care needs for patients experiencing mild disease, kind of introducing palliative care, discussing what to expect with dementia. I've been shocked by the number of patients and families who, when we ask the question, what do you know about dementia and what to expect? They're like, nothing. I have no idea. So providing that anticipatory guidance, engaging in advanced care planning, talking about how to live well with dementia and how to support the caregiver, knowing that this is a very long duration of illness. There's new collaborations with the movement disorders group for Parkinson's disease and other related illnesses, as well as neuro-oncology, which has gone traditionally with our symptom management service.
And so as we start to look ahead, start to think about the additional work that can be done, the future collaborations that will be discussed in subsequent talks. We also think about the novel models of care like Natalie described and trying to get creative in ways to be able to introduce palliative care earlier on when people are going through the process of being diagnosed. Many people know in this room it can be many visits to a neurology office before arriving at a final diagnosis. And so in speaking a little bit about educational things that are happening too, we've been very lucky to be able to work with the neurology residency, be able to create lectures and workshops, to be able to think about ways to be able to deliver some of this content to trainees earlier on in their clinical exposure too, so that it becomes more of a normal part of their ongoing practice. And as we look ahead to that too, we also think about the hopes for additional sessions, the idea of a training program for any provider that is interacting with this patient population, from physicians, social workers, chaplains, pharmacists, psychologists. The goal being to really help all of the providers that are working with these patients to feel comfortable being able to identify and manage the distress that comes up.
next steps. There's a lot of work we want to do over 25 more years plus. Okay, so a lot of collaborations in process that we hope to grow. We really want to do this interprofessionally, which means more than the three of us. There's obviously lots of folks in the division that have little spikes of this work or big spikes, so weaving those together more. We have dreams of fellowships and centers and strong community collaborations, and we hope you'll join us. Thanks so much.